This study was strongly supported by Professor Carlo Alberto Pagni, who told me to go ahead in studying the effect of spinal cord stimulation in vascular system, cerebral vascular system, after the demonstration that it affects peripheral coronary circulation. As we know, cerebral blood flow is 60 cc of blood every 100 gram of central nervous system for minutes, and it is guaranteed by cerebral autoregulation, which works through a myogenic, metabolic, and neurogenic mechanism. And it works when cerebral perfusion pressure, which is the difference between systemic arterial blood pressure and intracranial pressure, is among 150 millimeter of mercury. Cerebral autoregulation is well known to everybody, and we know the opposite effect of oxygen, pH, ATP, sympathetic, parasympathetic balance. Nevertheless, there are some physiological, paraphysiological mechanisms in which cerebral blood flow can change, like hypercapnia, hypoxemia, pyrexia, arousal, rapid eye movement, anesthetics, epilepsy, obstruction of venous outflow like sinus thrombosis. As a matter of fact, spinal cord stimulation indications are pain, spasticity, bowel bladder dysfunction, angina, peripheral vasculopathies. But the one who first published the effect of spinal cord stimulation, cervical spine, and thoracic spinal cord stimulation on cerebral blood flow was Osobushi, who detected an ipsilateral increase of cerebral blood flow when stimulating the high cervical spinal cord. Our group, at the time I was involved in the Melio group, demonstrated a clear effect of spinal cord stimulation on blood flow as studied with transcranial Doppler sonography. This is an example of increase on velocity during cervical spinal cord velocity, and no change during thoracic, low thoracic spinal cord stimulation. Such a phenomenon was repeatable during the time. In the upper panel we have a clear increase the first day of stimulation, the same increase after 425 days after the implant. On the other hand, thoracic spinal cord stimulation produces a decrease in cerebral blood flow, as demonstrated with transcranial Doppler sonography, which is a velocitometric examination, not so precise as a true flow metric method like the SPECT. By using the 133-7 study SPECT, we confirmed such a phenomenon with an increase in cervical spinal cord stimulation, no change in thoracic spinal cord stimulation, and sometimes a decrease in low thoracic spinal cord stimulation. We tried to better understand the underlying mechanism by studying an animal model. We studied the rabbits harboring a cervical epidural electrode, and we detected the bull cerebral blood flow with a true flow metric device called transonic in the rabbit, after closing the external carotid artery, so detecting by the common carotid artery all the intracranial compartment. And we demonstrate that after 5 minutes of spinal cord stimulation in the animal, we have a striking evidence of an increase in the cerebral blood flow, steady stating in the next minutes over the time. Among the literature, the first demonstration then medullary reticular formation stimulation produce an increase in cerebral blood flow was made by Reis in 1984. Osobushi, 1 year later, confirmed the evidence we had shown just before, and our group in 2 different occasions confirmed also with different methods such an evidence, also confirmed by Mazzone. But if we want to have a glance vision of what was published at the time, we have the Spanish Pool, 1994, again an Italian one, Isono in Japan, 1995, Sager in USA, Lee, 2008. But which was the mechanism underlying such multiple observations? Still a mystery, but probably Reis was right when he hypothesized a rule of spinospinal reticular pathways. The one who's involved, the same which is involved in arousal or coma or vegetative state, awareness or minimal conscious state. According to Takamitsu Yamamoto presentation, we have a segmentation of functional interference in a CBF or pain in spinal cord stimulation. The most likely segment of spinal cord involved in cerebral blood flow increase is C2-C3. And starting from such an evidence, we continue to study in our labs the effect of both spinal cord stimulation and sympathetic stimulation, since it was hypothesized from the beginning that a sympathicolysis, reversible, functional sympathicolysis during spinal cord stimulation was one of the leading forces producing an increase in cerebral blood flow. What will we do? We isolated the sympathetic chain at the neck of the animal. We put an electrode in the posterior aspect of spinal cord, cervical spinal cord, C2, C3, according to Linderer's definition. And we did what we now will see. Please look at the lower panel of this slide. This is at rest without spinal cord stimulation, without sympathetic chain stimulation. We have 100% of cerebral blood flow. As soon as we start to stimulate the sympathetic channel at the neck, we have a vasoconstriction, so we have a decrease in cerebral blood flow. And when we stop to stimulate at cervical chain, we have a returning back of the cerebral blood flow at 100%. But when we start to stimulate at cervical level with spinal cord stimulation, we have the well-known increase in cerebral blood flow according to Osobushi observation. But during spinal cord stimulation, when we start to stimulate again sympathetic chain, we have a decrease in the spinal cord stimulation effect. So we have the confirmation that spinal cord stimulation and sympathetic chain stimulation counteract each other, and very probably spinal cord stimulation, in order to increase cerebral blood flow, needs to interfere to block the sympathetic chain. Furthermore, other demonstrations were published according to the literature available, and you see there was a big deal of interest in the beginning of the 18 up to the 19, but as soon as we reach 2000, we can collect few observations both on the experimental point of view than clinical application and involvement of such an observation. Why? Probably because the clinical practice is different from the lab. As demonstrated by this experiment that was made the first time in 2000 by a Japanese neurosurgeon. He claimed supposed rule of spinal cord stimulation in preventing vasospasm. And we also decided to prove if it was true or false in the animal model, the same we have shown. And concluded our study in 2001. What we tried to demonstrate, if we put some autologous blood in posterior cranial fossa, in cisterna ambiens of the rabbit, we produce several vasospasms, mainly located at the basilar system, as demonstrated by this panangiography. But when in the same animal we start to stimulate 20 minutes before the injection of this blood, autologous blood, in posterior cranial fossa, we don't produce anymore any vasospasm. So spinal cord stimulation is able to prevent spasm in the rabbit, and the type of spasm we studied was the early spasm, which was first demonstrated in 1970, and it is the first phase of the vasospasm due to subarachnoid hemorrhage, which was considered very useful in our lab because it has a very short natural history. As soon as we inject the blood, we produce 1 hour phenomenon of vasospasm and reduction of the early spasm, up to consolidate it in 2 or 3 days later on with the classic vasospasm with the peak in the 7th day. Our conclusion was that spinal cord stimulation prevents cerebral vasospasm, at least our model of early vasospasm in basilar artery in rabbits. And this observation was awarded in 1996 at the International Neuromodulation Society and the meeting of American Neuromodulation Society in Orlando, in Florida. But why it was not employed in clinical practice, used as a therapeutic tool for patients? Why? Probably because the clinical situation, the clinical theater is quite different from experimental. Many other communications were published in the literature, but no clinical routine practice. Another information we tried to produce in 1993 was the rule of cerebral blood flow in ischemic patients. This was one of our patient harboring a middle cerebral artery occlusion stroke on the left side, and as studied with the transcranial Doppler and the SPECT, we demonstrated that during stimulation there was improvement not only of spasticity, pain, and bladder and bowel dysfunction, which are related directly with the neurogenic damage of the stroke, but also on dysphasic disturbances, suggesting a metabolic rule of spinal cord stimulation, not only a neurogenic rule mediated by neural pattern, neural tracts inside the central nervous system. And probably we state that, or suggested that an increase in cerebral blood flow was able to produce such evidence. 18 more patients were included in another study performed by using SPECT, transcranial Doppler, near-infrared spectroscopy, and we demonstrated that near-infrared spectroscopy during spinal cord stimulation produce an increase in oxygenated hemoglobin consistent with an increase in cerebral blood flow and a decrease in hydrogenated hemoglobin. So, strongly further supporting the role of spinal cord stimulation in metabolism, as was confirmed also by SPECT, which is a metabolic study of cerebral blood flow, shown a redistribution of cerebral blood flow during spinal cord stimulation more than an increase in penumbra areas. That's why probably spinal cord stimulation was not employed in a clinical practice for cure stroke patient, because redistributing does not mean restore in the lesioned area the cerebral blood flow. Also, Bushi concluded in his paper, although no mechanism clearly responsible for this intriguing therapeutic efficacy can be proposed yet, further clinical trials on spinal cord stimulation for inoperable cerebral ischemia may be justified. And so far, no clear indication in spinal cord stimulation is stroke in order to merely improve blood flow has been accepted. The literature data as well as personal observation seems to suggest that preventing rather than therapeutic effect on spinal cord stimulation on cerebrovascular disease models in animals. And we think that it's important, and probably this society could push and encourage to further investigate on the therapeutic rather than preventing effect of spinal cord stimulation on a cerebrovascular disease. The literature data as well as personal observation seems to suggest that preventing rather than therapeutic effect of spinal cord stimulation on a cerebrovascular disease model in animals. Thank you so much. Thank you so much.